Hi, and welcome to everyone. Great to have you here. My name is Shabir Musa. I'm a family physician in South Africa, as well as the executive coordinator of the African Forum for Primary Health Care. And we have started these series of meetings for the South Africa chapter, in some ways trying to find ways in which the AfroPHC mandate or mission to advocate for primary health care, appropriate primary health care for universal coverage in Africa will be undertaken in South Africa with a bit more localization. But I think considering the speaker today, we've shared it quite widely. And we're really pleased to have Dr. Cara Hansen, who is someone that I think we're really pleased to have available. Cara is basically a professor of health system economics and the dean of the Faculty of Public Health and Policy at the London School of Hygiene and Tropical Medicine. She has over 30 years of experience in health economics research, focusing on low and middle income countries, particularly in Africa and Asia. So I think she'll speak very well to our context. And she has spent extended periods in working in Africa and has led several large multi-country, multi-partner, cross-regional research programs. Her research interests include healthcare financing, the operation of the healthcare markets, human resources, and the economics of delivering priority health interventions. The reason she's here is that she's chaired the recent Lancet Global Health Commission on financing primary health care. And I think that's a really important document, which I think we hope today Cara will give us an overview of. And I think that we want to try and make the conversation as interactive. So after she presents, we're going to allow questions and answers. I'm going to lead some of that questioning around some key challenges in the African context. But I think our complaint largely at the global discourse is how very little particularity there is being paid in many aspects to primary health care. I mean, human resource issues are just not paying attention globally to exactly what should happen in primary health care. And in financing as well, the global discourse was not there until I think Cara led this particular commission. So I think it's one of those places where if you're really wanting to promote primary health care, this should be a place we should be talking. And we hope that you can contribute later. So thank you very much for joining us. Cara, thank you very much for being with us and being able to spend the time with us. We really do hope she can bring both herself and other resources she commands globally in this network that she's leading to continue this conversation, I think, amongst providers. And I think that she's no longer in the space of economists and policymakers. These are people I'm looking across and I'm seeing a lot of people who work on the front line. Who would appreciate a better understanding of this. And of course, with the limitations of our particular provider thinking, I hope that Cara can make it very easy and understandable for us. So over to you, Cara. I'm sure you can share. And I think lots of interest growing in the participant list.
Well, thank you so much, Shabir. It's such a pleasure to be with this group today. I should tell you that the Southern African region is very dear to my heart because my very first job as a health economist was in the Ministry of Health in Eswatini, then Swaziland.
Wow.
DI fellow, and I spent 2 years as the planning officer in the Ministry of Health in Swaziland. So
wonderful. This is like home.
So it's like home, indeed. So I'm going to share my screen, but I need someone to tell me if I'm sharing the right thing, because I always have challenges getting things in the right display. So if I do
financing healthcare, primary healthcare, we can see that.
If I put it in slideshow mode, can you see my
it's
slide?
telling to go into
just swap them around.
Yeah, I think just change the display. Very good, much better.
Marvelous. Okay. So I think I'll probably talk for about 20, 25 minutes. And I am I am aware of the audience, so I'm going to use the language of health financing, but I would hope that when we get to questions, if there's sort of concepts or language that's unfamiliar to you, that please feel free to ask me what I mean. I'll try to translate as much as I can as I go on. So as Shabir said, I'm going to be talking to you today about the work of our Lancet Global Health Commission that reported, we were actually published a couple of weeks ago, but the launch of the commission took place at the beginning of April, on April 7th. So it's just over a month ago. So it's very much hot off the press. And we're really very, very pleased at the reception that it's received and the interest that has been stimulated in it. So I'll tell you just a bit about the commission. The commission, why are we not moving? There we go. So the commission, the starting point for us, of course, was the challenge. And the challenge we can think of as the just the foundational, not just fundamental, but the foundational importance of primary health care as that place, that platform where essential health services are provided, where chronic conditions are managed, where it is the front line in responding to epidemics, such as the one that we've been experiencing over the last 2 years. And it's really a prerequisite for achieving universal health coverage and the Sustainable Development Goals. But as Shabir noted, not only is kind of the appreciation really of PHC insufficient, but the resources allocated to PHC are often insufficient. And they're delivered through either ineffective or inappropriate or unsupportive financing arrangements. And that means that the services are often inefficient and poorly performing, that they provide a lack of financial protection. And there I mean financial protection to users. And you'll see why the concern about financial protection of users. But basically, it means that people having to pay out of pocket at the time they're ill. And so when I say financial protection, what I mean is protection against that need to pay out of pocket at the time of illness. And of course, there are all the inequalities in access to care. And those are geographic inequalities, but there are also inequalities across a whole number of other dimensions. And then the other challenge that faced us, so we started, our first commission meeting was almost exactly 2 years ago. So it was in May 2020. And we were just at the very beginnings of the pandemic. And it was, I suppose it probably wasn't as clear to us then as it ought to have been. We didn't, how really profound and long-lasting the COVID pandemic would be. But even then, we were recognizing that the pandemic has created not just a health crisis, but a fiscal crisis. And it also has drawn attention to the dangers that societies face if they don't have a PHC system in place that protects everyone from ill health. So we were invited by Lancet Global Health, which is an international journal, to construct a commission to reflect on this. And so we were a commission made up of 22 commissioners, among which was Mark Bletcher from the South African Treasury. I'm sure someone who's known to many of you. But the other commissioners were drawn from technical agencies at the global level, from some of the bilateral and multilateral development partners. We had very highly esteemed researchers from universities, both on the African continent and elsewhere, and then people who worked in kind of think tanks and advisory roles. And that commission was then supported by a technical team that ran the commission out of the London School of Hygiene and Tropical Medicine. And of course, we ran the entire thing remotely, which I still have a bit of a disappointment about that. I think when I think about the pleasure and the intellectual stimulation that comes from sitting in a room and hammering things out, we did the best that we could with our technology, and I think we all got better at the technology over time. But to have drawn the whole process to the end without ever having met the commission face to face is a source of sadness to me. But we did our best, and I think we've come up with something that's still quite interesting. So the objectives of the commission were these. First of all, we wanted to draw together the evidence on the levels and patterns of spending on primary health care across countries. We wanted to analyze the key technical and political challenges in financing PHC, and then to really identify what are the areas of promising practice. So what are countries doing well that other countries could learn from to support primary health care across the key health financing functions? And I'll describe those health financing functions shortly. And then really to identify some actionable policies that would support national governments in raising and allocating and channeling resources to support effective and people-centered PHC. So our approach is described in these blobs. Really, we started. We were very intent on our recommendations being driven by the evidence. So the evidence that we drew on were some new primary data that we collected through the Commission. We did a survey of how PHC providers are paid, and so the provider payment mechanisms for PHC across low and middle income countries. And we ended up getting responses from about 75 countries across the world, covering the vast majority of the population in low and middle income countries. We drew on secondary data on PHC expenditure. So this was taken from the Global Health Expenditure Database that WHO managed. And we made some adjustments to it, really for two types of adjustments. One was to be able to bolt onto it data from high-income countries as well, taken from the OECD, the Organization for Economic Cooperation and Development, which has also had a PHC focus for the last couple of years and have been generating and publishing expenditure on PHC for the OECD countries. And to make those data sources compatible, we had a little bit of manipulation to do. But we also made some other adjustments to the WHO data to get them closer to what we thought was a better measure of expenditure on PHC. If anybody has any questions about that, I'm happy to take that up at the end. So we had our provider survey, we had our expenditure data analysis. We also undertook a number of country case studies. I'll describe those in a moment. We did loads and loads and loads of systematic and scoping reviews of existing evidence in the published literature and the grey literature. And then we had a couple of very focused expert meetings, in particular one on the role of digital technologies in financing PHC. And sort of based on that evidence, we drew together our analysis. These were the country case studies we did. Now, if I was, I think when we started out, we thought that what would be important would be to know which countries had increased their spending on PHC and how did they do it. And that's actually a question that can't be answered with the additional data, with the existing data, because the systematic collation of expenditure on PHC has really only started since 2016, the first data are published for. And so there's not enough of a time trend to say where have there been changes, so which countries have increased over time. And then use that as a sampling approach to identify countries for case studies. So instead, we just drew rather carefully on our experience, our knowledge, and knowledge in the literature of countries that were doing some interesting things and seemed to be having some promising results in terms of mobilizing additional resources for health, allocating those resources to PHC, and then through changing their provider payment mechanisms to improve the efficiency and effectiveness of that spending. So you'll see here we have countries from all different parts of the world. We had two case studies from Latin America, from Chile and Brazil. We had two from sub-Saharan Africa. One was Ethiopia and one was Ghana. And we had a couple from Asia, India, Philippines, and China. But we also wanted to make sure that we were learning from high-income countries. So we did case studies as well of Estonia, of New Zealand, and of Finland. In a sense, we were also trying to uncover the experience of those countries that are a little bit less well known. So I think the UK or the English NHS system for PHC financing is really actually quite well understood. So we wanted to be digging into those stories that haven't been told yet, where there was new things to learn. So I'm going to start by just giving you an overview of what the current landscape of PHC financing looks like, looking really at issues of spending and of provider payment. So the first finding of our commission was that the levels of government spending on PHC in low and lower middle income countries is really, really low. So this is, so just to unpack this a little bit, it's quite well established that that in order to achieve universal health coverage, the predominant source of financing needs to be from government sources, not from private insurance, not from user fees. By government sources, I would include both sources of financing that come from taxes and those that come from compulsory health insurance, so social health insurance, where there's a compulsory requirement or where it's often contributory in the sense that you have not just users paying premium, but also contributions from employers and sometimes from the government as well. So you can see in low-income countries, $3 per capita per year on PHC. That is just, it's so far away from what we think is needed to fund a comprehensive package of primary care interventions, which, there's lots of benchmarks for that, but it's really far away. And even in lower middle income countries, expenditure of $16 per capita per year is really far away from those sorts of benchmarks. And that really contrasts with the very high levels of expenditure in high income countries that you can see here. The second is that on top of that very low level of government spending, in low-income countries, you see many times that spending coming from out-of-pocket payments. So 4 times more per capita per year is spent from out-of-pocket expenditure than from government expenditure. Because this graph here comes from low-income countries, donors also fund a substantial share of primary health care. But we know that out-of-pocket spending is associated with financial catastrophe from health spending. That's where households have to spend more than a reasonable share of their household resources on health at the time of illness. And we know that these are out-of-pocket spending happens at the time when there's illness in the household, at the time when households are least able to pay for care. I think the other thing that's quite interesting, which I haven't got a slide on, but I'll just comment on, is not only do we have this kind of 3 sets of funding, two sources of which really dwarf government spending, but that spending is also very fragmented in the sense that most out-of-pocket spending is on medicines. Most government spending is on kind of outpatient services, personal services, and most donor funding tends to be on prevention and promotion. So you end up not just with fragmented funding sources, but also very fragmented funding destinations. And that makes it really hard, I think, for providers to work across their revenue streams. The other thing we explored is, does government spending matter? And so we just plotted that level of government spending on PHC per capita against what's known as the Uhc Coverage Index. So this is it's part of the infrastructure for monitoring progress towards universal health coverage. It's an index of coverage of priority services, most of which are PHC. There's a little bit in that Uhc index, which is hospital-based care, but it's not a bad proxy for coverage of PHC services. It's got vaccination coverage and ANC, and there's a whole bunch of services in that index. And the colors here are, the color blobs represent different income groups. So at the top right-hand corner, you can see in orange are the high-income groups, high-income countries, and you can see the purple ones at the bottom are low-income countries. So 2 things to take away from this picture. And I'm not for a moment pretending this is causal. This is just an association, but it's pretty powerful, isn't it? That shows that very strong relationship between the amount that government spends on PHC and the coverage of services that's achieved with that. So you see this strong, fairly clear upward trend, but so spending more is important. That's what I'd say. Higher coverage comes with higher spending. But the other conclusion we drew from this picture is that for any given level of spending, there's an enormous variation in the outcomes. So if you were to draw a vertical line at around $5 per capita, you'd see that countries' coverage levels range from a bit less than 40% to almost 75%. So, and what we conclude from that is it's not just how much you spend, it's how you spend it. And so that's kind of, I suppose, the main takeaway from our report is that countries should spend more, but they also need to spend better. And then learning about how to spend better from the evidence of country experience is part of what we wanted to look at in our report. The next couple of slides, that all those data come from the Global Health Expenditure Database with the adjustments that I mentioned. The next two slides come from our own survey of provider payments. This was this was surveys where the outcome is measured at the country level. So the question is, what is the main way that public primary healthcare providers are paid in low and middle income countries? So we've got these three bars here. And we divide provider payment here into four different groups. So one is where payment to providers is primarily for inputs. So that's usually in the form of a global budget for providers that's broken down by different categories of inputs. There'll be a line for salaries, for drugs, for cleaning materials, for electricity bills and utilities, that kind of payment system. And then you can introduce other types of, so then we look at other types of payment as well. So services means kind of a fee for service. So providers are paid on the basis of the number of services they receive. Capitation is where providers are paid a sum for every individual who they serve over a period of time. So you receive a capitation for a quarter or for a year. And that's either a capitation for people who register with a provider if you have a registration system, or it's based on some notion of a catchment population. And what you can see here is that input-based budgets are really the most common way of paying providers in low-income countries. But still, even in lower middle and in upper middle income countries, they're the dominant way of paying providers. We start to see a bit of capitation in lower middle income countries, usually blended with other ways of paying providers. But that's, I'll say a bit more about provider payment, but that notion of blended capitation, so capitation as the core of a payment system, and then augmented by other ways of paying providers to achieve specific objectives, is one of the core areas that we would suggest that countries look at going forward. The last slide of data here is this one here, which is about autonomy, because having control over resources, not just having the resources, but being able to make decisions, is also really an important way of ensuring that services are responsive, that inputs are combined in an efficient way. And here you can see for a number of different aspects of care provision that very few countries have any degree of autonomy on these. And so these things like, can you procure medicines? Can providers choose the mix of services that they provide? Can they hire and fire their own staff? And across all of these, there's really very low levels of control and autonomy. Perhaps the sort of medicines procurement is an interesting one, because on the one hand, you do want providers to have autonomy to be able to respond to drug shortages, for example, through some form of local procurement. But you probably don't, for efficiency reasons, want every single small provider to be doing all of their own procurement. So there's some middle way here, but I think to have some autonomy over emergency drug procurement is probably very important. So now I'm going to shift to our key findings. And we really organized our report around what health financing experts would recognize as the main health financing functions. And those functions are revenue mobilization, so generating money for health, pooling those funds, so bringing those funds together on behalf of a population, and then the second is I suppose the third function. Well, let me argue against myself here. Resource allocation we added in as a function, and one of the reasons for that, it's not a classical health financing function. It's believed to happen through pooling and provider payment, but actually PHC is kind of special in the sense that many countries don't have PHC as a budget program. I know in South Africa, you do actually have a PHC program budget, which makes you quite unusual in terms the focus that it provides on PHC, but the vast majority of countries really don't have a PHC program. And so when you ask the question, well, should we allocate more to PHC? The question is, well, what do you mean by allocating to PHC? Are we allocating to programs? Are we allocating to interventions? Or are we allocating to providers? So we wanted to really take on that resource allocation question. And then we looked specifically at provider payment as well. But we also recognized, I think this is one of maybe the more important contributions of our report, the great importance of political economy and of understanding the political and social and economic context of policymaking in around PHC. I'll talk a bit more about that later on. So our findings are organized around those main categories. So the first finding is really around mobilizing and pooling funds for PHC. And I think that the case is fairly clearly made that there needs to be more public resources for health in order to be able to allocate more public resources for PHC. And that this is an important element of limiting the need for user fees, out-of-pocket payments at the time of use that pose this constraint to households. And we also felt that it was important not to shy away from the question of taxes. And again, I would include compulsory health insurance as a form of taxation. It's kind of an earmarked tax. So existing tax collection needs to be strengthened. The tax base needs to be expanded. The number and types of taxes that are levied needs to be expanded, really in order to generate enough resources for health as a whole. And we also recognize the political element of that, because taxation policies, obviously, it's outside the purview of the Ministry of Health. I think that's a really important political point. It's ministries of finance, of treasury that decides on taxation, but also the kind of relationship between government and powerful elites around taxation as well. The last point I just want to make here is about pooling arrangements. So it's when one is creating a risk pooling approach, so an insurance bringing funds together approach, like the NHI that you've been proposing in South Africa, you have a choice about what services will be covered by that. And some countries have opted to focus those risk pooling arrangements on secondary and tertiary care and have not covered primary health care. And we would argue, on the basis of a kind of a progressive universalism approach and an efficiency and effectiveness of spending approach, that pooling arrangements should first cover PHC and make sure that everyone has access to PHC services without significant out-of-pocket payments before we start worrying about what goes on at the higher levels of the system. And the reason for that is because this sort of frequent exposure to illness that can be managed at the primary care level can also be impoverishing. Managing chronic conditions requires a constant use of healthcare and constant expenditure. And you think of primary healthcare as being kind of cheap, but it's really not if you have long-term conditions and chronic conditions that need to be managed. So I'm actually going to skip over the next picture because I don't think it says much more than I've just said. But I would like to talk a bit about allocating resources to PHC. So in a sense, my previous points about raising taxes for health was about raising resources for health as a whole. But once you've got a health budget, then the policy decision is how much of this should we allocate to PHC? And as you'll recall from my data, that government spending on PHC is far short of the minimum amounts needed. And so increasing budgets for PHC is what's needed, but this is not just technical, it's also political. And I'm sure that you will know far more than I do about the status that PHC has in health systems, whether that's your pressure to fund hospitals because they're located in urban areas and they're very visible, or whether that's the stature that PHC holds within the professions as well, and the low status of PHC for career development. So allocating more to PHC also has to wrangle with all of these political issues. Also, PHC tends to prevent illness. It may not be very visible. PHC is often about helping groups that have quite little, meeting the needs of groups that have very little political voice. So it's a political issue to spend more on PHC. the next kind of bit of our inquiry was, well, how do you allocate more to PHC? And what we wanted to do was identify what are the policy levers through which funds are allocated to PHC and where can they be used to increase allocations. And we described three main sets of policy levers here. So one was the way that budgets are formulated. So I've already commented that program budgets for PHC can be one way of making PHC visible in the budget and increasing resources to it. Other countries have used budget rules and appropriation rules to say that certain shares of the budget needs to be spent on PHC. Or conditional grants, in a fiscal federal system where you have budgets that are located to provinces, say, and as in the case of South Africa, where then it's the provincial government that decides how much to allocate to health and elsewhere, that there can be conditional grants where the center can influence the allocations of the decentralized units by matching funds, for example. If the more you spend, the more we'll give you as well. There's a second set of tools around budget execution. So how are those budgets actually spent? So having some kind of resource allocation formula is one way of building in protection for PHC resources. But there's also a number of other elements of budget execution that can strengthen resources for PHC and make sure that they're protected. So the contracting and monitoring arrangements for providers can help to protect resources for PHC. In many countries, particularly in other parts of sub-Saharan Africa, resources just never quite get to the front line. There's a budget, but it never makes it to the front line. It gets pulled off, either reallocated or pulled off in other forms. And so direct facility funding, getting cash to bank accounts that are controlled by facilities, has proven to be a useful way of getting some resources to the front line. Having a very clear specification of the benefit package helps as well. And then provider payment, although it's really it's a way of paying providers, it's also a way of protecting resources for PHC, particularly if it takes the form of capitation. The third set of policy levers are about how you structure service delivery. And it may seem strange to think about service delivery arrangements as a financing tool, but they really are when you think about it. So having a clear operational definition of PHC supported by norms and standards gives you a bargaining tool at the budget table. Say, well, you need this. You've committed government to staff us at this level and to provide this level of infrastructure. So that helps to pull resources out to PHC. Having a referral system and gatekeeping is also a way of protecting resources for PHC. And some countries have actually increased their spending on PHC by really changing their service delivery model, introducing community health workers, as in Ethiopia, introducing a new cadre of family health practitioners or general practitioners, and creating all of the infrastructure needed to develop and deliver service through family doctors is one way of pulling resources to PHC. So rather than trying to push it down for the top, you can change the bottom end and have that pull the resources to the PHC side. So just two very brief final points. One is that countries will have to apply more than one tool at a time. No one of those is enough to increase allocations or to protect them to get to PHC. And the other is that it's got to be really clear where in government the responsibility sits. I would not suggest that there needs to be a division of PHC in every government ministry. However, it's got to be clear where the responsibility for budgeting for PHC sits to help to both improve the accountability and the visibility, but also to increase the political support for PHC. Then we looked at provider payment, and Shabir, you mentioned in the introduction that many of the participants in this meeting are frontline providers. So I don't really mean salaries to individual providers. I mean to a provider organization. How does a provider organization receive its money? And we normally think of provider payment as falling into a few different categories. You can be paid on a fee for service basis. It can be a fee per episode basis. There can be performance-based payments, so payments for achieving certain targets. You can have input-based budgets, which I described earlier, or you can have these capitation payments. And we're of the view, well, first of all, that the way PHC providers are paid and the incentives that those create is really important. They can help ensure that resources reach frontline providers, and it can have incentives in terms of shaping how resources are used. And we believe that population-based or capitation-based payment is the best way to pay for PHC. And there's a number of kind of principles there. One is capitation is based on an equity notion. There's the same amount per person. That can be adjusted for people who have more needs. So it's not just horizontally equitable, it can be vertically equitable as well. So people who need more care, the providers can get a higher payment for them. It also, capitation, in contrast to the other payment mechanisms, it pays providers to manage population health and to prioritize prevention and promotion. And it also gives a predictable and stable revenue basis to PHC providers. So we really do feel that capitations should be at the core of provider payment for PHC. Now, what we mean by blended provider payment is that every way of paying providers has some disadvantages, and capitation has some disadvantages as well. One of them is that there can be an incentive to underprovide care for capitation, with capitation. And so what we would suggest is that as national systems get more sophisticated, have better information bases, are better able to manipulate incentives, that you should have capitation at the core, but have other types of payment mechanism around that. Let me give you an example from the English NHS, where we always think of our GPs as being paid by capitation, but in fact, they also receive some income on a fee-for-service basis for doing some types of services that are particularly high priority. They also receive some income on a pay-for-performance basis. So they have certain targets in terms of screening and I'm not even sure that I know the types of targets that they're dealing with, but this quality outcomes framework attempts to get them to work more to improving outcomes and rewards them financially for that. So you have a system where you've got capitation at the core and then blended, and by blended I mean it brings in other provider payment mechanisms as well. And we've kind of sketched out a pathway for how countries can get there. So you can see that main dark blue arrows, it sort of plots out a move from a status quo, that might be budgets or it might be fee for service, towards a simple capitation model, and then adjusting it for differences in population need, and then bringing in these other provider payment tools as well. And I think what we recognize, there's a few other dimensions to this diagram. There's a lot going on in here. One is that on the vertical axis, you can see that reflects a better alignment of incentives with the goals of PHC. And along the horizontal axis, you can see it also implies an orientation towards a more strategic purchasing approach. And then building up underneath my dark blue arrow are a lot of the other capacities that are needed to move towards this system. I'm doing for time. Oh, bad. Okay, I'm going to go a little more quickly. The last component of our analysis was around the political economy of financing PHC. And we thought it was really important that, that policymakers and analysts or researchers are very clear that this is not just a technical undertaking. This is a political undertaking. It involves redistribution in lots of different ways. Changing provider payment involves a redistribution among providers or also among different parts of the health system. And getting a kind of a coalition in support of really increasing the prominence and the weight of PHC is as important a part of change as designing the perfect technical solutions. And so our story on political economy is really one about building coalitions, about sketching out a pathway to change, and about having your technical solutions there in the background when the right political moment presents itself, and being able to pull out some technical plans when there's an opening. And so having those together so it's because of political dynamics and forces, it's being really opportunistic. So I'm going to go very quickly through my recommendations. I think you'll know what they are already from having heard me speak. So one is that people-centered financing arrangements should have these characteristics. They should be broadly based from taxes, that pooling arrangements should cover PHC, that resources should be allocated equitably, and they should be protected so that they reach frontline PHC providers, and that we would advocate that countries move towards blended provider payment with capitation at its core. And then the other recommendations are here, so that countries should need to take a whole of government approach. And this means in different systems, it means different things. It may well be working very closely with the authorities of decentralized bodies, so provinces or states in a fiscal federal system, but also working very closely with ministries of finance and treasury, because they're the ones that ultimately control the purse strings, and understanding what arguments need to make to them to get them to spend more. And that's often about arguing that you're going to spend better. So those two things are very closely related. That technical strategies are underpinned by an understanding of the social and economic and political conditions. And then we have also had some recommendations around the reporting of PHC expenditure, really for the global agencies. So I will stop there and just really recognize the commissioners who served for 2 years, giving all of their advice and insight and analysis and energy. And I'm very grateful to all of them. Thank you.
Yep, including Mark Bletcher, who's actually joined us. So really thank you.
Is Mark here? Excellent. Hello, yes. Mark. Nice to have you with us.
Hi, morning, Cara and Professor.
Thank you, Mark, for joining us. So I think obviously we have a very wide audience. I think some of them from beyond Africa even. So you're most welcome. I know the group is really about South Africa, and I think some of the people participating, we will talk to South Africa, but I think we'll keep the language so it's relevant to everyone anyway, and perhaps simplify some of the terminology so everyone's clear. Just to make a pitch, I think the African Forum for Primary Health Care is a space where we want to advocate very explicitly for primary health care. We want to bring as many of the people that are interested together. So please join the AfroPHC and join, when you join in the South African group, if you indicate your country, you'll be part of the series. And we are going to go into more depth around some of the higher level issues, which I think Cara's already talked to, but a bit more clearer, deeper about what that means. And I hope that Cara and others who can contribute will be part of that process as well. So there have been questions, and I think perhaps I'll just pick some of them, but if you want to ask the question personally, please feel free to raise your hand, and then we can unmute you and allow you to speak. But I'm going to just pick up in the meanwhile. Peter B asked, I think he makes a statement, but I think he raises an issue that I picked up on. You've mentioned high income countries having good or high expenditure and as a result, good coverage. And I think that's a pregnant statement, because does it mean outcomes are good? And that's a big question, which I think Peter's asking. Was there some examination of not just spend, but outcomes?
I think the easy answer to that is no, because there's very little in the way of comparable cross-country data on outcomes. I think the only outcome that's measured is mortality in both infant and under 5, and it's pretty hard to attribute all the differences in mortality to the effectiveness of PHC. So I think we realize that we're not all the way through that causal pathway, but that I suppose that coverage of key services is necessary, if not sufficient. But that issue of quality of services, because the difference, I suppose, between coverage and outcomes has a lot to do with quality. And we discussed endlessly issues about whether financing instruments were a good way of influencing service quality. We kind of came down to the view that it's not a very powerful tool for influencing quality, that there's lots of other things that need to happen. So for quality, you need a minimum amount of spend. You if you don't spend enough, you cannot possibly have quality. But there's so many other policy instruments that are much more effective at encouraging quality that we chose not to focus on that.
Well, I would disagree. I think that financing is quite powerful, but it needs to lay the basis for others to work. Because without giving, for example, provider autonomy incentives and allowing them to actually manage things, you're unlikely to get other policies actually working. And I think the point you make is important, is that, spend better, not spend necessarily more. And I think the US shows that lots of money doesn't really add up to good value, and I'm sure that pans out to primary health care. So thanks, Peter. Peter, there was a question from Rachel, who raised a question about tax revenue being applied in pooling resources for PHC. But I think it raises another problem, is that, and I think it's everything, I think, just as a aside, you've said it, politics matters. This is not without a political underlying problem, and we all have to appreciate that. And I think lots of the questions speak to that dynamic. But if it is that governments, which is sensible, governments which is spending 1 part to 4 parts of out of pocket, were to be able to get that money, pool it, and then be able to apply it better in a population method, hopefully including donor funding as well. In Africa, especially, everybody's hackles raised because they think, I'm this few taxpayers, and they want to take more money from me. And then they want to put it all together. Oh my God, they're going to sit and eat it all. And of course, South Africa is no exception, but I think somehow South Africans think they are exceptional and that everybody here is totally corrupt, and that's how it works. But the world's a corrupt place, even the US and all sorts of places. So Cara, give us some dose of reality. I mean, how do we, you as a high level group across the globe says pooling's good.
So
how do you deal with corruption?
So I'm going to warn Mark that I'm going to ask him to jump in here as well. I'll give.
How do we manage funds like that? Yeah.
Yeah. So I guess there's a couple of things. So without pooling, it means that households face the risk of having a big expenditure that can be catastrophic for their household resources. So the alternative to some form of pooling is facing a great deal of risk. And we sort of know that on average, people would rather insure against a risk. And I use insurance not in the sense of buying insurance, but in some sense, paying a small amount for sure to protect them against the gamble that they face if they do fall ill. And that's a really economist's way of thinking about what pooling does. But that's the principle of insurance. And that insurance function that says you don't have to face that gamble every year can be provided either through taxation or through insurance, buying insurance. I think the interesting about taxation is it's kind of this point you made about the small number of taxpayers. And so, and that is something we thought about a little bit, was what is the tax base? Because you're right, in a lot of places, the number of corporations or individuals who pay tax is actually really limited. So there's a question of what's the right tax, but also how do you broaden the tax base? And how do you broaden the tax base when you have a lot of people in informal employment? Because it's really easy to collect income tax if you've got a pay slip and your employer can deduct it and send it to Treasury. But if you have a lot of people working in the cash economy, in the informal sector, it's really hard to collect that. It just is. There are some other taxes that can be levied that people don't necessarily feel that they're paying them. So maybe they're better. In Ghana, for example, a chunk of the income of the social health insurance fund, a tax on mobile phone use. So when you buy your airtime, it's a bit of that is tax, and that goes to the health system. And I don't think people object to that nearly as much as they would object to more income tax, for example. So thinking creatively about taxes is important, but I can't see any way of protecting households from out-of-pocket payments without some kind of pooling.
Well, thank you, Cara. And I think let's ask Mark if you can talk to the generic question of taking a South African example. How do large pools of money get sort of protected from looting? And is there any higher risk with, for example, the NHI, the National Health Insurance System in South Africa? And perhaps that's been a lot of the conversation. And maybe Mark can speak to this, and maybe generically enough for other African colleagues to also see how it might apply. Thanks, Mark, if you don't mind.
Okay, thanks. Good afternoon, colleagues. It's a pleasure to join you, and Prof. Mercer and Prof. Hansen. And it was really interesting to be part of the commission. Let me just start. Sorry, I'll just try and reflect a bit more broadly than just on corruption, but on some of the other comments that have come up here. So let me just start. If I can just read out Joseph Anna's comment to everybody, which I think it really fits in very well with some of the work the commission did. But I think a lot of the comments that are in the chat here are really excellent. So Joseph Anna says, it is impossible to improve when low and middle income countries are spending $3 per capita. That's government expenditure on health, which is what the commission found after looking at about 100 countries' budgets for primary healthcare, particularly low and middle income countries. So there's an average of $3 per capita. And it goes on to say, out-of-pocket spending then is mainly on drugs. Government is spending on buildings, but they don't have well-stocked dispensaries. Donors are spending on capacity building and data collection. And how do you deal with this fragmented financing mix? And I mean, we found this. So what the commission found really is that unlike financing of health in general, that because I mean, governments often fund tertiary hospitals, but if you look at funding primary healthcare, the majority of funding of primary healthcare in Africa is out of pocket. So it's quite interesting that, because that drives a lot of different things. And in fact, even if you look at the South African, what is it called in the medical schemes, the minimum benefit package, or the PMBs, the prescribed minimum benefits. I mean, in South Africa, the prescribed minimum benefits don't largely include primary healthcare. Isn't that an astonishing thing? You know, that wouldn't be the case in many countries. Of course, later on, 27 chronic conditions were brought into the PMBs. But, you know, as a country, we have not yet seen primary healthcare as a minimum benefit. And I think that's what the commission basically argued, looking at this picture, is that you cannot, if primary healthcare is the most important part of the healthcare system, you can't deal with it, you can't fund it adequately if it's not in the minimum benefits. And you need to get this kind of central pooling arrangements for to fund primary healthcare. Now, the arrangements for pooling differ a lot in different countries. I mean, you know, many countries like Germany and Holland have multi-scheme arrangements. Some countries have single fund arrangements. And I think the jury is, you know, still not completely out on where we will ultimately end in South Africa. Obviously, at the moment, we have a situation with provincial pools, district pools, private sector pools. We have a particular bill that's before the portfolio committee, but there's still a lot of water under this bridge. And primary care is a very decentralized thing. You know, I do think that the digital vibes issue and other related potential corruption issues in South Africa have raised a lot of concerns about a kind of central funding model, which I do think the portfolio committee needs to look at quite seriously, because in a sense, one needs to, given the experience over recent years, to look at how models may need to be adjusted and made more topical. I think the reality is, after some of these events, what Prof. Mercer was saying is, I think he is picking up a deep-seated concern about the potential of monopolistic funding pools. So, look, there are many ways to skin a cat, but the broader principles the commission is laying out, that one needs to, PHC is not an add-on. PHC needs to be, there were many people who initially used to say, there is catastrophic expenditure, which tends to be, high-level hospitals, which should be centrally pooled, but PHC is not part of that. I think the commission has taken a totally different view to say that PHC needs to be part of the core expenditure. It needs to be part of the priority. The priority funding, the pooled funding. It's not to say there can't be add-ons of all kinds and separate funding pools adding on, but it needs to be part of this core, and it needs to be substantially funded from government funding. I mean, there can be other sources as well, but it needs to be substantially funded from, and that's what the commission found in a lot of Africa. That's not the case. Out-of-pocket spending, particularly for medicine, is the majority of the funding.
Mark, before I get to Siva Pillay, who's got a question, I want to just quickly ask you this. just because of what you said. You know, in a way, government did talk in South Africa about a risk equalization pool as a way to find ways to bring about some pooling in the private sector. It failed. Why do you think that was? I'm not sure that. Hello, Mark.
It failed. I wouldn't say it failed because it was never.
Where was the problem?
It was not implemented. I mean, the whole idea of a risk equalization fund is a progressive way forward in a multi-scheme arrangement. Mm-hmm. And I think we still need to see the way ultimately the way the pooling arrangements work in South Africa, but there may still be a role for risk equalization. Risk equalization is an excellent intervention in a multi-scheme arrangement for making them more equitable and balance the different funding mix between the pools. So, I'm not sure that the current version of the bill will be the last one. Whether it's passed like this now or not, whether the committee makes changes, these things tend to go through changes over time. So I think there's still going to be a lot of water under these bridges, but there's definitely potential role for risk equalization.
Okay. Before I get to Siva, I'm going to just allow you to unmute in a sec, Siva. I think just to explain, risk equalization essentially is to address a situation, and I think most of us in South Africa would be aware, where Discovery, for example, tries to attract a particular person into its scheme, very young, who actually have a less health expenses through other sort of gimmicks like, the vitality scheme, gym memberships, free flights, etc. And that pulls in a particular young set who feel, it's a little bit cheaper. And old people go to the schemes where they say, well, actually, that gives much better benefits and they don't give all the gimmicks. But what that creates is an inequality in pooling that threatens the different pools. And unless you bring that risk together, you will not have a sustainable approach. And you actually take out that element of trying to play the population risk, which is not a sort of solidarity-based approach. And in fact, it provides profits, but it's not good for the country. So just for those who might not have understood what we just talked about. So I think Mark says still place for it. Siva, go ahead. Thank you for joining us. A quick introduction.
Yeah, thanks. Thank you very much. It's very, very interesting. And thanks to the presenters for a wonderful, wonderful presentation. I've been involved with this from a long time, from 90 or before. And you always have a dream that in my lifetime, I hope at some point in time, the NHI will be implemented. And now it's becoming almost, I'm losing hope that whether I will actually, NHI will be implemented in my lifetime. But, what worries me is that we seem to be reinventing the wheel all the time. And there's this commission and there was many things. But, it's good that Mark is there because Mark has been there for a long time. There was an enormous amount of work done in South Africa. And, when we wanted to implement the NHI much earlier in the 1980s, an enormous amount of work has been done, which seems to be just swept under the carpet now. There were things done about pooling, different types of pooling, alternative sources of revenue, revenue collection, revenue distribution based on the district health system. Then coming back to that, we came to say, what is the
Siva, you'll keep your comment brief, I hope, just to allow everyone else.
Okay. All I wanted to say is that I appreciate this, but I think that we need to bring it back into some form of consolidation because there's too much of fragmentation. And, like you talk about risk equalization. Risk equalization was an intervention to bring about a change in a multi-party system, a multi-funding system to a universal system. So it was an intervention. It is not a means to, it was a means to an end. But in this fragmentation that we are looking at and no coherent policy going forward, we are losing our focus on getting things done.
Absolutely.
I think we need to really focus to say what is primary healthcare and how it can be done. And I actually wanted to pose a question to Mark because I actually believe that NHI can be implemented. If you remember in the olden days on a district health system, every district municipality could collect regional council levies, they could collect employer-based taxation, and actually implement a primary healthcare NHI system in a district without any regulation and law. I actually tried to do it in Utne. I succeeded to a certain extent, but it didn't work because of revenue retention not being passed.
Absolutely. I think
I just think that we need some innovative ideas and we need some bold people to just take this thing forward, because we've been talking about it too long and doing too little.
Absolutely. I think Siva has done some amazing work in, Uitenhage, like he's just mentioned. Setting up capitation, we'll come back to that question and some of the challenges that were faced. And I think essentially the challenge that was faced by that group of providers who initiated was that it was based on the goodwill of one payer, which was a large institutional employer in that area. And of course, the big problem was, that the sort of arrangements around pooling were too extensive, or not the pooling, but the risk management were too extensive, in that included, hospital payments. And that became a lot to carry by a small pool of providers. But I think it was an amazing experiment. And I'm sure any of you have got, can touch base with Siva and, the work he's done. I think some of it's documented. Perhaps let's just go to a question. I think, Cara, maybe Mark can also answer this. It's a very theoretical question, because I think it's all political. Like you've just said, what percentage of health budget Karen asked the question, what percentage should be allocated? I mean, that's a big question. I mean, Mark can perhaps raise it. I mean, I know the UK, 8% of the total budget spent on primary health care, versus South Africa, where I get something between 40 to 45% spent on primary health care. But, it doesn't equal anything. What we get in South Africa isn't equal to what happens in the UK, and nor does the real amount as well. So I think it's a big, pregnant question. I'm not sure that they will answer exactly like that, but that's the same question that, Ebi Kapai asks, what's the best way to work out primary health care, secondary care, tertiary care, how proportions go. So let's see if you can answer that, or you do much the same. Thanks, Cara.
Oh, Mark, do you want to have a first go?
Yeah. How do we work the sort of appropriateness? Yeah.
Okay. Well, let me just say that I tried to bring this question into the commission, but Cara told me very early on that we were not going to be prescribing norms for spending. We did examine some of the global norms. You'll know, for example, WHO has called for certain increases in primary care funding as a share of GDP. But and we did look at some cost global and South African cost models. Let me say that even some of the people in the audience have helped us with some of these cost models. For Chef Fenta, for example, who's here today, worked on a project for National Treasury. It was one of 3 costing groups that looked at a normative costing for primary healthcare in South Africa. And Prof. Musa himself also helped us to develop some model templates that a national health insurance could contract with family practitioners, both legally, and also we had an actuary involved looking at the nature that a fairly sophisticated kind of capitation plus arrangement. It included capitation plus various incentives, and it was kind of a mixed reimbursement model could be designed. So, careful costing can help to inform the answer to that question. We do have some numbers for South Africa on what we think some of the splits can be, but the Commission specifically didn't want to put such numbers in the public domain and enter this normative terrain. Am I right, Cara?
Yeah, no, you're absolutely right.
Good, you deflected it nicely.
One of our editors said, no, really, you have to have a number. And we said, we're not going to produce a number, but here's some of the numbers that others have produced. So I suppose, so what's interesting to me is whether you take a share approach or a level approach. So WHO has said the country should spend, is it like 1%, an extra 1% of GDP on PHC? Mm-hmm. But they have also, the PHC team have also costed a package of PHC, and I can't remember what that number is. I'm going to say like it's around $50, but I could be wrong. Mark, it's the work that Karen and her team did. They did come up with a number and said this is a package. This is what it costs based on costing norms. But actually, and some people in the chat are saying, so what share of the budget should go to PHC? Should it be 8% or 20% or 40%? And they're all different ways of answering the same question, really, isn't it? But I suppose if I had to, my preferred technical approach would be to follow Mark's line of defining a package and costing it, then looking at what that would be as a share of the total budget and seeing how far I am away from that in current spending. So to sort of bring in that political lens to it and say, okay, well, maybe I can't get to that costed-based norm, but I should be able to because suppose the cost norm would say 30%. I'm only at 10%. Then I would say, okay, let's moderate that. Let's, instead of trying to spend 30%, because it's going to take us a while to get there, let's try to increase the share of spending on PHC incrementally each year, and then let's track our progress at it. That would be the way I would set about trying to get to a more normative approach. But I think yes, but I think starting with an empirical costing is probably the best way to do it. Also, if you're going to be if you're trying to be estimating the cost of a capitation payment, you need empirical costing data as well. You need to know how much is enough to get your providers to be willing to provide that benefit package at a reasonable quality. And then what other adjustments you need to do to make them want to play.
I thought it was rather interesting, and I think in some ways it's evidence-based. Take a model, make it work, try it out, and build it from there based on the costs, inherently in producing cost to effect. I was quite surprised by the number you shared at the beginning, which was the $17 by high middle income countries, which I thought, well, that's a high middle income country, but a high income country was way much more. So there's surely a benefit, is there any examination that they've been able to keep their costs relatively low, even though their income have grown? Are there better models in that? Because high income doesn't necessarily mean better spend, more results. So interesting to look at that. But I think in AfroPHC, we particularly are looking at the question, which, we've put out, is this model that we've put out in the, with National Treasury that Mark just talked about, is actually very simple principle. It's basically saying exactly what Cara has been talking about. Let's look at ways in which we can pool funds, get more funding potentially, but within the constraints of country, allocated through strategic purchasing systems to mixed capitation system to PHC teams who can then have the money to then do what's necessary. And for us to look at, can we compose such teams considering the shortages? And one of the big things that came to my mind as something that you didn't talk about, but I really would be curious to hear from you, is strategic purchasing such an important bit. Because in the African setting, the problem everybody says is, well, we don't have anybody in health, any doctors. But heck, and it's been mentioned in this chat, is everybody's going to go into the private sector because that's why you're not getting anywhere. So to actually find ways to pull them back into the public services, you're not necessarily going to try and take a dysfunctional system, throw more money at it. You're going to have to pull these private guys back in. And it's not going to happen just with salaries. If the system's dysfunctional, you're going to have to give them this provider autonomy. So how is that featuring in the conversation? Because in Africa, that to me is the real value of the potential change, to move away from the bureaucratic system to one where strategic purchasing, bringing in our private provider, and then giving provider autonomy. Cara, maybe Mark?
Yeah, no, it's a great question. And strategic purchasing is a topic that's very dear to my heart, because we've looked very closely at purchasing arrangements across, not in this work, but in work that I did previously with colleagues at the University of Cape Town. So I think there's a couple of challenges there. So one is, what do you do about the private sector? And I think that kind of depends what kind of private sector you have. And one of the things we know about the private sector is it's enormously heterogeneous. I think in South Africa,
growing as well.
growing, but it's also, but you know, if you, in South Africa, I realized that you've got a much more kind of formal, well-established private, you know, medical sector. If I were to look at many other low and lower middle income countries, they've got a private sector that's made up of doctors, great doctors, terrible doctors, half-trained doctors, untrained people, some of whom are providing actually really unsafe and dangerous care. So I would say, so in terms of how to deal with the private sector, I'd say first, can we get rid of that like dangerous?
But isn't that a way to do that? Because you're bringing them into the formal system.
Well, precisely, and that was going to be my next point. So how do I do that? So to get the really dangerous ones that are not really qualified, I'd say, let's provide a decent public sector alternative and compete them out. Right, so that there's no need to go to them because I've got, you know, a financially and physically accessible public service nearby to me where I could use instead, and maybe their business will just like drop out. I realize I'm optimistic, but then as my system develops more capacity, I think, can I use my power as a purchaser to engage the formal private sector in my system by contracting them just like I do my public providers? So how can I put them on a level playing field? And I think that's, you know, there are definitely countries that are doing that. They tend to be more at the upper middle income level because you need a whole bunch of other stuff to do that well, right? You need an accreditation structure of some sort where you can make a decision about who do you want to play in your system, and that you have some form of accreditation. And you need a really good purchaser that's able to gather and process data, not just purchase and you know, a strong audit function, and not just financial audit, but also that kind of clinical audit as well. Make sure that you're getting what you pay for. And so that kind of gradual accretion of system capability gives you the grounds then to do something really good with the private sector and to have them contributing to the system rather than providing as a parallel system with different financing arrangements. So that's definitely the destination that I'd want to get to. And to me, the question is, how do I get there? What does the pathway to that destination look like? And it's, you know, there's a little bit about my provider payment trajectory. Those underlying systems at the bottom, those all apply to purchasing as well. So you need good data systems, you need good audit systems, you need some quality assurance, you need some accreditation. And as those get into place, then it becomes possible to purchase effectively from the private sector.
Yeah. We've got a person with a question. Anna, go ahead. Feel free to ask a question. I'll just look through the chat group to see if there's some other thoughts.
Hello from Finland.
Yes.
Hello from Finland.
Welcome, Anna.
Yeah, just because you mentioned that you used Finland as a country for comparisons. I wanted to say that Finland has a special model that emphasizes in welfare. That means that they start thinking from the social determinants of health. And they start from the, let's say, the starting point of health is not the healthcare setting only, but some, let's say, social measures, for example, for people, as example, people in adolescence, people who get drugs or alcohol, they do alcohol abuse, and there is a very strong care for prevention. That is a way also to reduce the costs of healthcare before you go to doctor. This is one thing. And the other thing that may be interesting for you all is the following, that Finland changes the healthcare system. And from next September and on, our system is separated in 21 districts, which will follow their own healthcare models. And we are looking forward to see if that will be successful because before the healthcare system was based on municipalities, but the taxation comes directly to municipalities, and the municipalities pay the costs of healthcare. I don't know if that is valuable information for you. And I wanted to say that maybe in the future, if you are interested, we could see various comparisons, because we will have definitely national comparisons, but this could be also food for thought for other countries, if you are interested, to see what kind of implementations worked in which kind of areas, because we have also areas which are urban and areas which are entirely, how can I say, with sparse inhabitants, as example, the Lapland area, the Lapis area, Lapland. And that could be also a lesson to learn from the view, for example, of Saharan spaces and so. So I'm also economist, by the way, except of my studies in health. And I would be very interested to hear from you and keep a contact with you and check what we could do as comparisons, international comparisons.
Well, thanks, Anna. What a great bunch of issues. And I'd love to be in touch. So please do drop me an email and we can see if we can.
Yeah, thanks a lot.
I think you raised a number of really interesting issues. One is the thing that probably distressed us the most in the commission was, what is our definition of primary healthcare? And
that's the first problem.
And I'll say where we came down on that, which was we recognized and acknowledge and value the very broad kind of original alma ata PHC that recognizes those social determinants that Anna talks about. We decided that our focus was on the part of that that's funded by the health sector, that we were really targeting our messages.
Primary care, essentially.
So while not at all denying the importance of education and social care, they're not our financing problem, because government budgets, now it is a financing problem. It wasn't our financing problem. It's a huge question of how do you finance kind of multi-sectoral action? And I think we don't have any really good models for that, but we didn't really take that on. The second point, though, was about, so one was about the optimal level of budget holding. So should you get money to providers or should you get money held at a higher level? And there's lots of countries that do different things. So Chile and Brazil, it's actually the municipality holds the budgets for PHC. So the budgets don't go down to the individual provider level. In some parts of sub-Saharan Africa, where these real problems with the public financial management system, and there are real blockages, resources just don't get to the periphery, then that's where there's been a move to get money to the facility level, because in a sense, because the system doesn't work, it's kind of bypassing in a non-functional system. So I think it's a really interesting empirical question: is what's the optimal level of budget holding? And we'd love to look at that again. The third thing you said was about how do you deal with the capitation system in particular? How do you deal with this the problem of sparse populations, which is a problem in lots of parts of sub-Saharan Africa? One, because it may well be that you've got so few people in your catchment area that the income that comes from their capitation is just not enough to cover their fixed costs. They actually need more money. And so countries have found ways around that. In Estonia, for facilities in sparsely populated areas, they get a base payment before the capitation. And that's just in recognition that the capitation income that comes from a small population isn't sufficient. So you have to adjust it. And that's where those having capitation at your core, but other means of addressing that resource question is so creative. But thank you, Anna. Those are great points that you made about Finland. And Finland is very interesting.
Yeah, well, thank you very much. I just want to quickly add to that point you raised and ask Mark perhaps to respond to it as well. You talked about budget holding and that difficulty of where exactly do funds lie in that decentralized format. What, Mark, is your sense of the idea in the NHI of a contracting unit for primary care, which is the idea in government, I think, of budget holding at a decentralized sub-district level? And how do you see that panning out versus provider holding the funds themselves? In other words, receiving the funds directly, and what are the dynamics around it? And perhaps reflect on your visit to Thailand, I think, around that. Would you mind responding to that, Mark? Because that's an important leg of primary healthcare funding in South Africa. Yeah, go for it. Thanks
very much. So, firstly, just to link that to Anna from Finland's point about district-based financing. So, I think there is a strong intention underlying the NHI thinking to have either sub-district called Contracting Units for Primary Health Care, the so-called CUP, which is in a sense partly inspired by the Thai CUP model, or district-based funding, and I guess it would depend also on the relative capacity of the districts or the sub-district or CUP. But more specifically, those of you who are from South Africa will know that Dr. Nicholas Crisp has been appointed as Deputy Director General of National Health Insurance, and he has asked to restructure some of the indirect grant for National Health Insurance this year, specifically to test some of these sub-district contracting models. So he's actually hoping to do some of it this year, and we have agreed to some reprioritization of the funds this year in that grant to test that. So, for those of you working very specifically in this area, I would encourage you to make contact with him and, to look at some, what pilots the department is looking at and how perhaps one could support these piloting initiatives. From the Treasury side, we're very, very keen to see positive examples of strategic purchasing, both at the district, sub-district level, but also particularly of family practitioners and group practices. So, in fact, for us in National Health Insurance, we would see this as, one of the really big next steps of reform, which could be so popular to users and to, and more broadly, colleagues from Croatia, for example, we had advising us also the head of the National Health Insurance in Croatia, and he was saying when they shifted to a family practitioner model, also where family practitioners had electronic dispensing, so they could write their script and it could be filled anywhere actually in Croatia electronically. Through the authorized script could be filled, and to give people greater access to their family practitioners, but also to medicines. And it was very, very popular. And I think this is one of the problems we've had with our South African reforms. There's a lot of talk, but not much effort in doing and actually making services attractive to people. And I think that a lot of people in South Africa want to use their family practitioner. So I don't think we should talk about whether public sector is better or private sector is better. I think we need a mixed provision model. We need to acknowledge that family medicine is, going to be key to the system, and we need to find ways to, through, whether it's public or private financing or a mix of them, it enables these kind of family-centered models. And, the strategic purchasing that Shabir is talking about is quite central to this. So, we're keen to see and support examples of this district or sub-district purchasing where, local teams are playing a key role in putting together what is the mix of provision and the models, and family practitioner group practice contracting. Thanks, Shabir.
Thank you very much, Mark. We are running to the end of our time. Cara did warn that she's going to have to leave by the half hour. So I'm going to allow Sunanda and maybe Henry would also like to make a comment. So Sunanda, I think you can just quickly raise your hand and then I know there are lots of issues. I have a paper full of little things that I thought I'd raise, but time's not enough. And I just want to say that we are going to have these monthly discussions. We'll see how it is, but it is going to go into some of these concepts a little more deeply. The question of, what is pooling exactly? A little bit more about it. I hope Cara can join us, Mark, as well, to just understand and flesh that out a bit. This was a very big overview, but we want to ask that question, what are the specifics and some of the discussions in South Africa about how do you create systems that protect that funding? If it is that way, and just to get this approach, strategic purchasing, capitation, and then some really sort of the model that I've done, the work I've done with National Treasury, I think it'd be very worthwhile sharing because it's premised very much on the point of view to get a family-centered approach, a community-centered approach. So let's leave it for future. Please do join the AfroPHC. I'm not sure that you'll get the notice otherwise. And just indicate, and we'll let you know. Sunanda, go for it, and then after that, Henry. Sunanda, you're able to speak. I think I've unmuted you.
Okay, thanks very much.
Thanks for all the comments in the chat as well. Thanks. Go ahead.
Yeah, I'm based in Botswana, but I have my main experiences in Zimbabwe. So a lot of what's being discussed about South Africa is out of our, and I think should be acknowledged for
sure.
most of Africa. Family physician-based primary healthcare, etc., is only in private practice. What I wanted to ask Cara, though, is this issue about community health insurance. So in the countries that have tried this, like I believe Ghana and Rwanda both have some form of community-based health insurance, has that made much difference, or is it all at a very low level and doesn't actually achieve the full range of healthcare possible in our context? Thanks.
It's a great question, Sunanda, and I will give you my honest answer, which is that it's a great idea in theory. So community-based health insurance is insurance. You pay a premium in advance to a pool that's usually held at quite a low level. Many countries have tried CBHI. I can only think of one where the coverage has ever reached a high enough level and been sustained. So they tried, they've been running CBHI in Nigeria for decades, and coverage is less than 5%. It's not a national program, it's just never really spread and been sustained. In Ghana, they eventually actually, to achieve the really high level coverage, they ended up the CBHI morphed into a nationally run system, as in Thailand, actually. So in Thailand, the insurance system there started with community-based health insurance, but what it really needed to take off was a substantial government commitment to it, and actually government paying for the, effectively paying the contributions in a national scheme. The only place that I am aware of where there's been a high and sustained level of coverage of community-based health insurance is Rwanda. Rwanda is a very small country. It's
a very disciplined country.
It's a very effective government, and a very developmental state, and the state is able to bring a lot of other resources and pressures to bear on households to enroll in insurance. So I think coverage is well over 90%. It has been sustained.
Cara, is it not still, and it eventually landed up with the same problem? In other words, fragmented pooling and not enough risk equalization that they eventually put it into the system.
They've built on the risk. So there is some kind of
right. So basically, it kind of morph it into a national system anyway.
Yeah, that's right. So it's still, so that the pools now, they pay a share of their revenue up to a higher level fund that then distributes it to equalize risk. So you do eventually need that, and that's one of the problems. One of the problems of a young CBHI is exactly as Shabir says. You end up with risk pools that are too small, and they're very vulnerable to inequalities in utilization or high levels of utilization, either because it's only the sickest people who enroll, or because you have a bad year. If you have a bad year and a lot of people get sick, then the
local illness, for example. Yeah.
That's right, and those risks are correlated. So I guess I think that CBHI can be a good way to introduce people to the idea of insurance, so that they get used to the idea of paying something in advance for benefits that they may or may not need during the course of the year. But its institutional restrictions are such that it's really hard to get enough people to join. It's hard to manage that cross subsidy, and often it ends up being described as a poor benefit scheme for poor people. So it ends up just being very restricted to what can be funded through that local. To be able to really increase the benefits, you need contributions from more than just those poor people.
Probably more a useful marketing tool to get buy-in into the whole national system.
Yeah. So Ethiopia is embarking on CBHI, and they're looking very much at the Rwanda model. Ethiopia also has very strong state capacity, so that it may be possible to get people to join in ways that it would be less possible where there's a less strong government.
Yeah, thank you, Cara. Henry, go for it. I think that'll be the last question, and then we can close up. Thank you, Henry. Go ahead.
As Dr. Musa knows, I'm working with Tanzania, and our Tanzanian colleagues, we're very thankful and are continuing to be thankful for your help in South Africa and helping us develop. We're way behind you in developing family medicine, but we're working on it in a community primary care scheme. The reason I'm talking at this point is the government has come up with something called ICHF, Improved Community Health Fund. And it starts at the bottom for somebody at Tanzanian poverty, less than 73 cents per family member per year. It will give you basic health insurance. the person has to pay $6 per person per year, which is a bit of a barrier. And the government then, in essence, matches that maybe a little bit more. And the basic health care, in a sense, for those very poor people is the catastrophic, because, you know, we've got a little girl with an imperfect anus that we picked up through that, you know, beginning of that system. We are able to then buy them health insurance in the general health insurance for the universal that they're building in Tanzania. And then they were able to go to the national hospital and get an operation for their imperfect anus. But the bottom line is that it's possibly a way to think about, and I love input from Dr. Hansen, we really want the equity. We want those very, very poor helped, and it doesn't go anywhere near far enough, but is it a first step? And the reason we're involved particularly is because the government has been failing. It's a good program, but nobody's signing up. The government health employees are identical to what Professor Hansen was saying. They've got zero incentive. They don't want any more people. They don't care. They're, you know, and to be fair, that they may care, but they really feel like it's a pawn in the system. And so our regional medical officers and district medical officers encouraged us in the health-based system that's, in this case, religious-based, in partnership with the family medicine development, to try our shot at it. And so we now are registered to see people in that model. And what we're trying to do is build from our community base, where we've been buying insurance through our mosques and churches and everybody helping the widows and the very poor, because it's been a focus. If you start with widows and orphans, it's generally, you're able to get some support. So anyway, the question is, thanks. How does that fit in the dynamics and what you're talking about?
So Tanzania is a great example, right? Because Tanzania is one of those countries where CHF, the Community Health Fund, that community-based insurance fund, trickled along at a low level of coverage for like 20 years. It never went over, you know, in some districts it went up to about 10 or 20%, but never higher than that. So that was a model. In the old model, the pre-improved one was exactly the problem that I talked about, getting stuck at a low equilibrium. So what you're doing, I think what you're describing is a situation where we're bringing in additional resources to top up those contributions, and that's precisely what's needed. So the only question then is, can it continue to spread? So is there both the financial commitment to bring coverage beyond those districts where they've got special help and support to bring coverage up, and then to build the infrastructure that supports it? And that includes this risk adjustment infrastructure that's needed to be able to adjust across pools as well. So it's I think it's super promising that the government is willing to and able to top up on a targeted basis for those groups identified as being below the poverty line, top up their contributions to make the benefit package worthwhile. That's one of the things that's really important. Right? It's partly that targeting the subsidy, but it's also to put enough money in the system that it actually provides a meaningful benefit, because you need that extra revenue into the pool to be able to provide a meaningful benefit. Because I think what people don't want to do is pay insurance premium for a service that doesn't
little value. Absolutely. Thank you very much, Cara. This has been a great opportunity. Really appreciate it. There have been 50 people who have hung on and really listened to all of your words. And thank you, Mark. I think great share, and all of you who've provided this, the interactions and the questions. Thank you very much. So, Cara, sorry for taking you 2 minutes longer than we expected, but really appreciate you being here. And I think everyone's found it of great value. So with that, let me say, great. And we'll explore further, Cara, about how we can get you to be part of, and others to be part of the series. I think you can see it's going to have broader value than just South Africa. And I think there are lots of little things. And I think if we're talking to a practical situation and with your experience of other countries, I think that really is really helpful. So I think it can become a broadly applicable engagement. Thank you all very much, Cara. Bye-bye, and enjoy. Take care, everyone.
Have a great weekend, everyone. Bye now.
Bye-bye. Bye-bye, Mark. Take care now. Thank you.